Hello, everybody. I'm Dr. K. Agarwal, President, Confederation of Medical Association of Asia and Oceania, and President, Heart Care Foundation of India, and past National President, Indian Medical Association, and editor of MedTalks. Corona Namaste to everybody, because the word Corona Namaste has brought us that we need to have a social distancing. So the word Corona Namaste is synonymous with social distancing. And when we talk about social distancing, telemedicine has to come in our life, in our practice, in our hospital, in our routine life, meeting people, social media. So social distancing is not possible without telemedicine. There was a judgment sometimes back in the Supreme Court where they said no telephonic consultation unless in an emergency. And therefore, always doctors have been talking about, is telemedicine allowed in our country or not after that Supreme Court judgment. And now we have March of 25th, new telemedicine guidelines. And that's what we are going to talk today. And we have a team of experts with us. I have with me Padma Shri awardee Dr. K.K. Sethi, who is the CMD and HOD cardiology at Delhi Heart and Lung Institute. He has been the past president of Cardiological Society of India, and he has also been HOD of a GV Pant Hospital in cardiology, a well-recognized face, a person known for his views in the society. I have Dr. Prasanna Kumar. The word Prasanna comes from the word Prasanna comes from Bhagavad Gita, where Krishna uses this word Prasanna much more than happiness. Anything Prasanna means something from the heart. And he is a past president of Endocrine Society of India, and he is a consultant endocrinology. Welcome, Dr. K.M. Prasanna. We have Dr. Sunil Mittal, who is the chairman of Cosmos Institute of Mental Health and Behavioral Sciences, who is the director of Asia Pacific World Federation of Mental Health. Thank you, Dr. Sunil Mittal, to be here, a person who is known to be amongst the celebrities, and mental health has a lot of role in counseling and giving treatment, and it has lots of legal issues. And Sunil has been doing a lot of telemedicine counseling in mental health, and he will be able to share his personal experiences. I have Dr. Rajshekhar Reddy, who is a director of neurology, and which is a institute, Max Institute of Neurosciences. Thank you, Raj, to be here with us. And all our viewers, the next 1 hour will be interactive. You can post your questions. We will take it up in the last 15 minutes. In the first half an hour, we are going to basically interact with each other, and we are going to talk about what the act is. Telemedicine now is a reality. On March 25th, 220, this has been incorporated into the Indian Medical Council Act as a telemedicine practice guidelines. And when I say telemedicine practice guidelines, it still does not cover invasive procedures and surgical procedures from a distance, like we talk about robotic surgery from outside. Still it is not covering, but it is still gray area whether I can do a remote ultrasound or not, whether I can. So a couple of areas are still remote, but that's what I wanted to introduce the subject. And then Vikhyat, can you have all of us in one frame? Okay, then I'll go ahead with I'll read out and then I'll ask specific questions. Then definition relating to telemedicine, it talks about diagnosis. That means I should be able to see a patient and give a diagnosis, treatment, prevention of disease and injuries, research and evaluation for continuing education of healthcare providers. And it basically talks about everywhere the word shall, not should, not could, not can. The shall being, it becomes a mandatory. Dr. Sethi.
Yes. Yes, I think what you said is very correct. That although all of us were, repeatedly and frequently asked to give views and opinions on telephone in the past many years, it's always been some sort of, uncertain area. And some of these private companies had also started some video consults for international patients, because I have been asked to do that a few times, trying to advise them on things. But then again, this was not something which was approved by the government. So therefore, it was being done at a very, very small scale, uh, basically to discuss with the patient that he should come in for in-person consultation so that we can further do the investigation and treatment, whatever is required. But as I see it, there are several issues that will come up with this. First thing is that regarding consultations, patients will definitely feel comfortable. Excuse me. But there could be some limitations of this kind of a consultation, and we will discuss that as time, passes by and other people have had their views. Most importantly, it will be good for patient follow up, because most of what you can get out of this is the history of the patient and how he describes his condition, and maybe take some visual examination of certain superficial parts of the body, and that's about it. But much more important is prevention of disease and injuries, education. Physician education will, assume a very, very major role, which has already happened during this COVID episode, because I see n number of webinars happening on various things every day. I have myself been a party to so many educative sessions outside the scope of coronavirus, because I'm not an expert on coronavirus, but that is the way it is being used. And continuing education of, public healthcare providers and any other, person connected with this, even including the communities. So this is going to become a big thing if it is used in the correct context.
Thank you, Kamal. And specifically, I want to raise 3 points, and then I would ask Rajshekhar to comment on them. The first point is that RMP may charge appropriate fees. So it is, you need to define your fee. The word appropriate. Fortunately, when the act was being made, they have forgotten to write about fee. And I was sitting with Dr. Paul, and we discussed together. I said, where are you not covering the fee? And then he dictated the word on phone that add the word appropriate fee. Otherwise, we would have been in a fix whether to charge fee or not. The second thing is that it is that the guidelines is a legal status. So appropriate fee, legal status. The third most important thing is that any violation made under the telemedicine guidelines will be considered as a misconduct at the hands of the concerned RMP, which is MBBS, under the code of conduct. As such, if the misconduct is proved, the RMP may be reprimanded or have their registration suspended or cancelled. See, the word cancelled means out totally. Suspension means temporary. So this is a very serious thing they have added. There are only 2 clauses in Medical Council of India where your license can be cancelled. One is PNDT violation, and second is a fake certificate. That means you are giving a fake certificate. So this is a very serious column they have added. Nobody has objected to it. The word they have written is suspended or cancelled. Suspension, if they would have written only cancelled, it could have been temporary cancellation. But if you are saying suspended or cancelled, that means, and that's the reason of this seminar, to tell our doctors that you need to be taking precautions. Don't take it lightly about the whole thing. Rajshekhar.
Yes, sir. So I think, sir, I think you've highlighted some very, very important points here. I think the first thing that everybody needs to remember is that when we are doing a teleconsultation, for all practical purposes, the doctor has to maintain the same kind of standards and status that he would do in a normal consultation. Just because this is a teleconsultation, he should not try to, let's say, cut corners or do if whatever is possible with this with telemedicine must be done at all points of time throughout the consultation. Regarding the fees, I think when you say appropriate fees, I think this would be very similar to whatever is being charged in the outpatient while we are doing a regular consultation. So there should be no real discrimination between a fees charged for telemedicine. And of course, it will depend on the speciality of the person, as well as the duration of time that one gives. And if this is the first visit or a follow-up visit. So if the timings are going to be different for these things, then an appropriate fee as per what is being charged regularly when a physical consultation is being taken can be done. So I think in terms of the fees, that is not, I think that, that is very clear. And when they say appropriate fees, whatever is happening in that city with that person's practice privately or in a hospital setting has to be looked at. Like I said, sir, I think the important thing to remember here is that when you talk about any law which can affect your licensing, it's something that one has to take very seriously. So when a patient is being consulted at any point of time, the first thing, of course, even when a patient comes to our outpatients in a hospital, we don't actually look for their identity cards. So he can come into the hospital OPD area, register by any name. It is not the doctor's responsibility when he comes into the room to prove that this person is such and such person. But while this is happening on a telemedicine, it would be probably prudent to ask the patient to identify himself, maybe send an identity paper prior to the consultation via WhatsApp message or a mail so that you have that documentation that this gentleman has his Aadhaar card or whatever documentation is available. So you know that you are actually giving a recommendation for that particular situation, because tomorrow it should not become a medical legal case that one is giving consultation for a person who was not physically there. He was in another city, and that person takes advantage, saying, I could not have committed a crime in Bombay because I was consulting Dr. Reddy in Delhi at that point of time. So it's important for us to keep these things in mind while doing these consults. And like I said, I think over a period of time, things will evolve further as we go on. We will learn from our mistakes. And for now, I have been using this at least for a month and more in this current scenario. And as I have gone on, I have seen that follow-up is easy to do because you're familiar with the patients and everything else. My specialty, neurology, there are certain advantages of being able to see a patient, certain things that we see when the patient is, his physical examination is not as difficult as it's a long examination for a neurologist, but we get a lot of input by just looking at the patient, how he is walking, how he is speaking, if there's any abnormal movements and such things. So I think those are very important things that we need to consider. And I think as we go on in the discussion, I'm sure that there'll be other inputs from other people, and I can expand on that.
Thank you, Raj. I'll take now Sunil Mittal into it. So Sunil, there are certain defined ways of consultations.
Right.
So the government says any patient via services. So one thing is very clear, that always make patient to call you. You don't call the patient. I'm telling all the viewers, make sure that the patient calls you, because if the patient calls you, no consent is required. This is implied. But if you call, then it is not an implied consent, because tomorrow you will have to prove that the patient has not given the consent. So always ask patient to give a call. And even if, whatever way, that's a loophole in the system which you should be able to use. He says telephone, so telephone is allowed. He says video, so video is allowed. Devices connected over LAN and WAN are allowed. Internet is allowed. Mobile is allowed. Landline phones are allowed. Chat platforms, see, remember what I'm coming. Chat platforms like, so they have defined the word WhatsApp, Facebook, I'm little bit worried, Facebook Messenger, not Facebook, etc. The word etc. they have kept a loophole for people like Practo and Labroad to come in, because the word etc. is a very dangerous word in a legal term, because then you open up the word etc. to everything. But they have written one thing very clearly, and that is all information shared by the patient shall be confidential, and the RMP is required to undertake a reasonable degree of care, and this reasonable degree they have not defined, in usage of platforms. These platforms are that etc. platforms for maintaining such confidentiality. That means it is, and when they say your license can be cancelled, therefore you have to be very careful that your data does not get leaked. Dr. Mittal.
Yeah, so I think a few things which are very, very important to the practice of telemedicine. and they're as important as they're actually as important in real life practice as well. When you're doing a face-to-face, a personal in-presence practice, the same sort of the sets of ethical principles apply. The telemedicine policy makes it amply clear that the same care, the same responsibility, the same sets of ethical principles and etiquette as defined in the MCI Code of Ethics in their eighth, the fifth, I think, the same principles have to be followed. It's no different. So it places an equal amount of responsibility on the physician, the RMP, as it does when you're practicing in your clinic. There's no difference at all.
No, what it means is, I want to agree. I want to slightly tell you is you more careful, not same equable, because
very more careful because
they are in prescription. There is no cancellation of your license.
That's right.
So here it is cancellation. So you have to be more careful than compared to.
Absolutely. So and in fact it goes a step further, like what you just said. That is not just same, but there's an additional burden of responsibility because you're getting data on a digital platform, whatever you use. If you look at the policy, it's a fairly advanced and actually, I would say one of the most advanced policies that we have. It allows you, it doesn't define the hardware. It doesn't define the software that you can use. You can choose. The whole purpose that every patient should be able to access medical care permits, you can choose whatever platform the patient wishes to, which means it could be a text, it could be an SMS, it could be an email, it could be an audio, it could be a video, it could be one of those social media platforms like WhatsApp or Facebook Messenger, whichever way. The patient can choose. I cannot dictate as an RMP, but I can also help the patient decide, or I can also choose. Now, the question which Dr. Rajsekhar addressed regarding the identity is extremely important because here, firstly, the telemedicine policy makes clear there can be no anonymity. So every time you're going on a consult, actually it says your name should be displayed and all your data should be displayed. So you need to introduce yourself that I am so and so. One is presuming that a patient in follow-up is already familiar, but we need to identify the person and therefore ask for a government-approved ID. In fact, I am aware that at least for psychiatry, what's being done is that NIMHANS is in the process of making a form which you send to the patient and the patient fills and sends you. But I think that can be used by everybody where the ID and everything, the personal data comes in. As well as that, that's one. The second is regarding the initiation of the consultation. So who can initiate a consultation is the patient, the patient's caregiver, a healthcare worker, as well as another RMP, and the types of consent required would be different. If a patient initiates a consultation, it's an implied consent. But if it is to be initiated by a caregiver or by another healthcare worker or another RMP, then there has to be an explicit consent obtained from the patient, which is laid down in the policy. So if it's a caregiver who says, look, my son or my father or so-and-so is having, then either I require a nominated representative that there is an authorization and the person has been authorized, or the person has to be present at the same time so I can see both of them. And the representative is also identified, and then I can proceed with the consultation. Same is with a healthcare worker. And therefore, so that's another, the implied as well as the explicit consent, which is mentioned in the policy. The third issue is of the confidentiality, which you brought up. Confidentiality in medicine is everything, because patients share their whole data, their own lives, their sexual lives. In psychiatry, they share their personal lives, everything. But they do so in every branch. So confidentiality anyway, the confidentiality of data to be stored, here the responsibility is on the healthcare provider. So that means a RMP. So logs have to be kept of the consultation, data has to be stored, notes have to be made, and they need to be filed. Whether it's an electronic medical record or it's a handwritten medical record, they need to be filed. Patient may upload reports, may upload other opinions, prescriptions, their copies need to be made and they need to be filed. So it is not that, well, I just saw it and just gave a consultation, but just like you would do in a hospital, but more here. You may not take a photocopy of a previous prescription in a hospital and file it, but here you would need to if the patient is provided. If they have provided a document, you will need to file it. Otherwise, it will amount to misconduct. And at the same time, breaching confidentiality. Say, if I was to release a video or a picture of a patient consulting me without the consent, then that would be misconduct. That's breaching confidentiality. And of course, we know this, we can't do it. Where the policy is silent, which is one of the shortcomings, is what if the patient releases a video of a doctor providing a consultation? That's one of the drawbacks in the policy. And the patient can do it because the patient could as well be recording audio, video. So there is a drawback there. There is another, the policy is amply clear that you can consult to anybody inside the country. Since the international patient question, which Dr. Sethi addressed, you can provide consultation anywhere in the country, in any state. If you're registered with one of the state medical councils or you're on the national medical register, you can provide to anybody in any state. However, it is silent on the international consultation. So it does not say you can provide internationally, it is silent. The catch there is, which is the jurisdiction that is going to apply. Even in our own country, it is silent on the fact, say I give a consultation to somebody in West Bengal. Is it the patient's place of residence jurisdiction or my jurisdiction, New Delhi? So these are left undefined. I mean, these are challenges which I'm sure we'll iron out as we go along. So consent, implied and explicit, confidentiality, definitely as much, if not more responsibility than on a face-to-face consultation. And then of course, the question of an alibi that a patient says, well, I was like what has been pointed out. The guidelines also mention that all your prescriptions must clearly mention teleconsultation. That you have to mention this just to that question of alibi. So a video consultation is considered the best. So you mentioned tele-video consultation or tele-audio consultation or whatever. So that needs to be mentioned, and they have to keep ourselves also safe from any further accusations or allegations or legal hurdles.
Thank you, Sunil. And I'll come back to Prasanna, and then I have a couple of questions with me, and which have come. And Prasanna, what Dr. Mittal brought up the issue. In a state medical council, the law today is that you have to be registered with the state. Say, for example, Delhi does not allow me to practice in UP, but in a Telemedicine Act, I will be allowed to practice anywhere in India. Medical Council of India also says that I can practice anywhere in the India, but there is a dispute between a state medical council. Now, if there is a patient in UP and I have given him a teleconsultation, where will he file a complaint? In UP or in Delhi? In UP, I am not registered.
I think patient, because we had this discussion with one of the High Court advocates, almost 1 hour. Actually, law is not very clear. Now, the patient, because he resides in UP, by and large, he will register a case in Uttar Pradesh. Now, the question is whether you have to go to Uttar Pradesh, the Allahabad High Court, and then you have to define, or patient has to come. There is no clear cut. We had discussed it, but the law does not say clearly where it is. But according to my own knowledge and the High Court advocate I discussed, he can file a case at Uttar Pradesh against the doctor, and then it is up to the court to say whether it should be decided in that court or in High Court, or how it has to be done. It is left.
So I'm going to give down, Dr. Prasanna, I'm going to give you a situation that as a advice to all the people, viewers who are watching this program, that when Dr. Sunil Mittal talked about the implied consent and the caregiver consent. So I'm going to say very simply is let the patient call and let the patient choose the platform. Then confidentiality of data and leak by the platform will lie on the patient. Instead of you telling him to come to my platform or this platform, let the patient choose from whatever platform he wants. That's one. The second thing is that when I'm in a situation where there is a service of a platform, I just gave an example. It can be Olympics platform, it can be Practo platform, it can be Liberate platform, it can be Apollo platform, and it can be DHLI platform. If I'm doing a platform, then I should do it. And in front of telling them, I should say, give me a Dropbox-like facility in your platform so that my data is not shared by you, not even seen by you. Like in YouTube, I have a Dropbox, and in Dropbox, my data is completely secure. So those platforms can give a doctor a Dropbox where I can keep the data of my patient and everything remains confidential. Dr. Prasanna.
I have been using EMR for the last 15 years. I'm the first one actually here using it. Absolutely no problem. Don't do telemedicine if you don't have EMR. Because whenever I consult any patient, whether telephone medicine, e-consultation, whether video consultation, I have done even hologram consultation also, I have EMR in front of me. When I do the video consultation, once I open, like I'm talking to you, I open KK Agarwal, I get your EMR. I see everything. Say, you are Mr. KK Agarwal, yes, your age is like that, previous, everything I get last 10 years of previous consultation, all the investigation, medicines you are taking, you tell your symptoms, I type, then I change medication, I send report at the end. Just check. In 10 seconds, you will get SMS, the whole prescription. You will get an email along with whole prescription, before food, after food, how many days, and how long you should take, what is the dose, when is the next consultation, what is the test next time, including my e-signature, KMC number, and my name and qualification, according to Medical Council of India. This is how we have to do. Doing teleconsultation without EMR has no meaning. I have all my patient 50, 60,000 in the cloud. Regarding security, one should remember who owns the data. Patient owns the data. It is patient's right to own the data. Now, when the patient comes to me, Dr. Mittal, what does he say? Sir, I'm giving this data to my psychiatrist or physician with an intention you will keep the secrecy. You are not going to reveal to anybody. This is an understanding between patient and doctor. When I go through any platform, which I'm doing 15 years, I sign a 3-page contract where all my data is safe and secure. Anything which happens, he is responsible. Don't take free EMRs, free consultation from somebody, and there is no such thing. Here I have been using 10 years. It is customized. And then 3 pages contract. Regarding consultation, I said, yes, when patient initiates telephone, email, whatever it is, video consultation he initiates, and according to the latest rules, High Court of Maharashtra, where the first case happened, not Supreme Court, I can tell you the name and everything, that said no video consultation at that time. Now MC has changed all the rules. When patient initiates, it's obvious. But how the life will change after COVID is, my advocate, my son is also a Supreme Court advocate, he told me, take one small, for every patient who comes, I give my consent for telemedicine consultation, video, blah, blah, and all. Every patient come to me after next month when I start the clinic, he will send whether he'll use it or not. Then I have something to say, look here, Mr. So-and-so has signed a consent for telemedicine. He may use it or may not use it. It takes 30 seconds. I don't have to do. My receptionist will explain along with the case sheet, everything it is there. Mr. So-and-so has given it. I am safe. The problem now is 2 things. One, for the last 40 years, I have got indemnity bond. I started with 48 rupees. It is thousands of rupees. No insurance company indemnity says telemedicine. Now all of us should say, please enter this telemedicine, because now the question comes whether MCA debar suspends is secondary thing. Am I covered under that? According to existing rule, what you have got a policy 2019 does not cover. 2020, please take it. Just telemedicine is it. Whatever mistakes you take, knowingly, unknowingly, one of the major mistakes occurs is when I am taking the prescription, I may make a mistake before food, after food, once a day, twice a day, or I might not have entered the pharmaceutical name. All these should be covered under the indemnity, then we are safe.
I agree with you, Dr. Prasanna, and Dr. Sethi. I'm coming back to you. That when Dr. Prasanna said that you must have an EMR, a GP will not be able to have it. A single clinic will not be able to have it. And so, what do you think for a GP or for a single or a joint family or a husband and wife clinic? What should be the best way for telemedicine?
It's quite a challenge actually that we have faced for last few days, because we are all not prepared for it, but we have had to give some consultations on the video. So at this time it is quite primitive. One of the important things that is written in this new guideline is, complete record keeping. And even for a telephonic consultation, I wanted to bring this point earlier also, that when the patient calls you, you have to tell him that I am Dr. So-and-so, and I am speaking to you for this particular consultation. I hope you agree on that consultation. And this call is going to be recorded. This is what was told to me, that if it's a telephonic consultation, perhaps you need to record the call. And that's a very, very difficult thing to do for us, because how will you record the call and where do you store that data? For a common doctor, it is not going to be easy. Video consultations are relatively easier because you can see the individual, but chances of making an error are a lot higher in telemedicine consults than when you are doing in-person consults, particularly in certain specialties of medicine where symptoms overlap for many diseases. Mostly the diagnosis is based on history taking, and at the most you can see patient's feet, or you can see the patient's face, maybe a little bit of abdomen, but the other things, you cannot physically examine the patient, you cannot listen to his lungs and all that. So possibility of making a mistake are very important, and therefore the moment there is even a slightest of doubt on the history that this patient requires in-person consultation, it should be immediately advised to the person that you need to come to the clinic. I cannot go beyond this. Or it looks like an emergency to me. So you please report to a hospital in emergency so that you can be examined by such person. For example, in cardiology, if we have a patient with heart failure, which is not a very uncommon thing, it's a common thing to treat patients with heart failure, and they come with cough or with difficulty in breathing. It can be a lung issue. It can be worsening of heart failure. It can be blockage in the artery. It can be anything. So there are multiple differential diagnoses of a complaint. And telemedicine has this drawback. For simple ailments, it is relatively easy. But even there, simple cough and cold medicines, when combined with antihistamines and certain antibiotics, particularly in vulnerable groups of patients, and I'm just saying this as an example, sometimes can cause serious consequences as far as heart is concerned. And it has been talked about amply in the case of hydroxychloroquine and azithromycin combinations when being treated for COVID. And I have myself had several discussions on the cardiologist platforms on this, that you need to risk stratify your patients as to, is this drug going to cause any harm? Is there a drug-drug interaction with anything else that the patient is taking? And particularly with psychiatric medicines and heart medicines, there are a lot of interactions. So you need to see all these things and never rush for writing a prescription without seriously considering all these things.
Thank you, Kamal. I'm going to come back to you. Now we have 25 minutes left. So I'm going to ask each one of you 3 minutes each. Quickly tell about your specialty and the telemedicine. And the last 10 minutes, we will take the question answers. So I'll start with Rajshekhar, telemedicine in neurology.
Dr. Gopal, telemedicine neurology has been there for quite a while now, and there are three particular situations that we end up using this in. One is in the emergency, when a patient has come to the emergency with, let's say, a stroke, and it's 3 o'clock in the morning, you can't rush there immediately, and the patient requires to be treated immediately. Then the doctor there who is available can video consult you by showing you the patient, showing the power of the patient, showing any kind of facial asymmetry, to prove that this is the degree of deficit that a person has that requires an immediate agent to be given, for example, a thrombolytic agent. Or in the case of a status epilepticus, you have a person who's there in the emergency who takes a video of the patient or is live streaming a video where you're having seizures or any kind of movement disorder, which can be shown from the emergency. So that's the first thing, and that I think is a great help to a neurologist who is seeing such a patient, and it gives you a lot of confidence in being able to prescribe a particular course of treatment in that sort of situation. And then you have two other conditions in which, two other situations where such a thing can happen. One is the patient having an emergency at home, for example, a seizure. Again, to identify that a seizure is happening and advising the patient to get to the nearest center will be also very useful. And then there's the routine consultation, where a patient is consulting you for, let's say, a migraine or for vertigo or for any other such situations where they don't have to come into a hospital immediately. In that situation, again, I think video consults are a great, and I say video consults because as a neurologist, I do not like to speak to people on the phone. I want to see them. If they tell me that this is what is happening to their hand, they're shaking, then I want to see that shaking. I make them walk across the room. It also gives the patient a lot of confidence that they have seen the doctor and they have been able to show the doctor what is happening. So when that happens, I think it helps to, in my mind, their confidence in being able to take that medication. We try not to change medications too much. If a person is having a seizure disorder and is mostly controlled and cannot get to a nearby hospital, unless it's a great emergency, we will tell them, listen, whatever is going on, if you're mostly all right, don't change it. And we would like you to continue the same medication. So those are the principles I go by. One, if identify emergencies, you can treat emergencies in the triage with the help of video consultation or teleneurology. Identify emergencies at home, make sure that the patient is given an emergency medication at home if need be, if you've already given them that, for example, a midazolam spray for seizures and things like that, and tell them to get to a hospital. And then the conventional consult, where they are consulting you and you're helping them out. By, for example, headache, you can ask for symptoms of red flag. Was there a sudden severe headache? Is there anything else to suggest raised intracranial tension? So I think video consults are the prime thing I would go by. And of course, this is dependent on the technology that's available to the patient or the attendant of the patient who's there, and they should have a good internet connection. Because if that's not okay, then you should not go ahead with the consultation. Especially
so the Act also says anytime you can withdraw from your consultation. That's the Act says very clearly. And in emergency neurology, yes. For second opinion, yes. For giving opinion on somebody else's opinion, yes. But in certain cases where you need to see the fundus, till the technology is available of a remote telemedicine of such facilities, there you will have to call. And the Act also says whenever you feel, call them. Dr. Prasanna in endocrinology. Yeah. Telemedicine in endocrinology.
Yeah, definitely. Because endocrinology and diabetes is mostly armchair medicine, if you know. And I have been using this for more than 10 years. As I told you, 15 years EMR. I do telephone consultation. I do email consultation. I do e-consultation. I have done the video consultation. Also, I have been doing WhatsApp consultation only recently after this. What is it that they do? 95% of the patients are diabetics who need e-consultation or telemedicine. What is it they want? When I start insulin, I put patients who are only on insulin telemedicine, because once I start insulin, every 3 days, they have to check blood sugar, fasting, pre-lunch, pre-dinner, send it to me. Whether they have an Excel sheet, send that along with the insulin dose. When they send, I get an SMS, you have a paid e-consultation from so-and-so. Once I click, I get EMR, including patient's photograph, age, his height, telephone number, address, everything, BP I've entered, everything there, all previous records, previous HbA1c, latest one. Then I go through that and I say adjust the dose. And once I say send response, he gets response to his SMS by phone as well as to his email. And once he opens emails, he gets a full prescription with an e-signature, everything before food, after food, this out. Now I started video consultation. There are two types of video consultation, again done with EMR. Somebody contacts my assistant. She says, okay, her smartphone, laptop and all that. Please go to this site, take an e-consult. Then she will say, old patients, what is your latest blood sugar, weight, whatever BP and other things, she will enter there. If they have not done, please go to nearest lab or ask them. Because of COVID, they will come to your house, collect a sample. Doctor wants all these tests. I have advised him in January, HbA1c, lipid profile, urea, creatinine. All these tests is entered and the data is entered in the lab investigation done today. So when she says, I have fixed up an appointment 6 p.m. today, video consultation, there is a waiting room, it shows red. The moment patient clicks, it becomes green. Patient is ready. I click on green. Good evening, Mr. So-and-so. I'm Dr. Prasanna Kumar. This is a video consultation. As Dr. Mittal said, I write, not examine patient. This is video consultation. Then I said, these are the medicine you are taking. These are the latest HbA1c, blood sugar, blah, blah. I'm going to adjust the dose. Are you happy? Do you have any complaint? Sir, I want to show something. Show me that whatever. Show me your hand. They can even show their foot. Take the mobile phone, show that. It is just seeing. Only I don't auscultate or percuss, which even if you see as an endocrinologist, how many times that has been useful for the last 10 years. The only two emergencies you see is hypoglycemia and ketosis. Hypoglycemia, you don't need anything. Have you done blood sugar? What are the symptoms? Take 2 tablets of glucose, 8 or 10 grams. Do another blood test, 10 minutes is all right. Don't go to a hospital, because you get admitted, you are going to spend thousands of rupees. Ketosis, yes, you go to hospital. Last 10 years, I got 2,400 type 1 diabetic children, 1-year-old to 30-year-old. They are given everything free, 44 centers across the country. Each doctor is taking care of 40, 50 children, giving everything free. These doctors in turn have a WhatsApp group, and they have a beautiful app where the child enters name, duration of diabetes, type 1, latest 3 blood sugar, insulin dose. Doctor is advising. How does these 2,400 children survive? If you put all these rules and regulations, many of them would have died long back. 10 years back, out of 1,000 children, every 2 to 4 child was dying per year. 80 to 100 admissions per year. Now, last 2 years, touch wood, not a single child has died due to diabetes in my setup. Why? Telemedicine. And whether it is telephone medicine, whatever it is we are practicing. So most useful. Parents are, some of them are less educated. They can't go to EMR and all. Simple is on that app they do. This is how telemedicine, telephone med. Coming to e-consultation, they take a prepaid card, like a prepaid your Airtel. You want 2 or 5 or 10, pay this much of money. There's a disclaimer. I am willing for this, for my blood sugar only. Nothing else. Not for fever, heart attack, chest pain, breathlessness or anything. So he will send the result every 3 days. And I get an SMS, you have a paid consultation, click, you see that, adjust the door. So from morning till night, anytime he sends anywhere in the country, at my leisure time answer, he will get an answer. Ask the patient, are you happy? 100% of e-consult, teleconsult happy. They say only one thing, sir, I feel Prasanna Kumar is in my pocket. Anytime I want, I send, within minutes I get an answer. What more you want? I have to travel 2 hours. It is rule of 3 hours to travel, 3 months before take an appointment, waiting 3 hours in the clinic, and doctor spend 3 minutes. It's not true in my case, many other cases. This rule of 3 is not necessary, where he saves money, time, energy. I also take money. Because as I become older, when I am now 68, if I am 70, 75, why should I go to hospital? Everything I can do. Till these rules, I was never taking first consultation, but now that means patient has to come first time to a clinic. I have done people in villages, panchayat members from far off villages doing e-consultation for the first time. Diagnosis done. He says, I am diabetic. Where is it? You are making diagnosis. You just have to see whether he has complications or not. For that, patient, when they come to my clinic, assistant will enter height, weight, blood pressure. Nurse will take everything. They will do a fundus ophthalmoscope. I got artificial intelligence which says fundus normal, abnormal. They take a photograph, attach it to EMR. When I open, I see fundus, ECG, foot care, everything is done. What is there for that?
Good. Thank you, Dr. Prasanna. This is a wonderful way of explaining what you have done. You are a role model as far as the telemedicine is concerned. Quickly, I'll go to Sunil and then Dr. Sethi. I want both of you to finish in 3 minutes each, so that I can take a couple of questions. Otherwise, I will not be able to take questions of the audience.
Sure. I'll limit myself to 3 minutes. I think psychiatry, fortunately for us, is a specialty which takes easy to telemedicine, because our interview, our examination is observation and talking. So just like for neurology, observation, therefore, the video consultation is a preferred mode of telemedicine. So my patients are using WhatsApp. We have a dedicated video platform. They use a video platform. They talk. They're more comfortable. They can choose a time. Like Dr. Prasanna said, there's no waiting. There's no travel. Huge saving. But more importantly, in psychiatry, we are faced with another problem. The National Mental Health Survey says about 14% of Indian population requires psychiatric care, not just emotional. We're not talking about the anxiety, stress. Psychiatric care. That you're talking about 15 crore plus people. And 6,000 psychiatrists in the country. So for psychiatry and mental health, it's a boon because you can take it far into the rural areas. And we have been doing experiments earlier where we were troubled because we could not write a prescription. We were connected to villages surrounding Delhi where we could consult, but then we'd ask the person to go to a GP and then we speak to the GP and then we'd say, okay, you can consider these medications. But they were also a questionable route. But now all this is fine and legal. The second thing that is there is psychotherapy, psychological first aid. My team of psychologists, there are 8 of them. Their calendars are full right now. Their diary is full and they're just doing it on telemedicine. Rehabilitation, psychotherapeutic and mental health rehabilitation. Currently, we have a program which we are running for the very sick people who don't need to be in a hospital because of an emergency. It's like a domestic hospitalization. The psychiatrists and the psychologists, they take a round every morning virtually, and the person is being looked after at home. We speak to the caregivers, there is education which is carried out, medicine which are prescribed, and the dosage adjusted. And EMR, of course, is extremely important to provide all the service. Now, with this, the other thing is emergency. I'll illustrate, sir, if I can have 1.5 minutes with 3 examples. We got a call from somebody who was extremely suicidal, who was in a place which was one of the first places to be locked down, Bhiwadi. So there was no way this person was getting out, had overdosed 2 times in 3 days. And previous psychiatric consultation existed. I was seeing for the first time. Now, the challenge is, how do you respond to such a thing on a first consultation? And obviously, all you can do is suggest something, say, I have not examined the patient, it's a teleconsultation, but the person needs to go to the nearest physician. And I will speak to the physician and help the physician understand what needs to be done. So he can't find a psychiatrist, but he can find a physician for an emergency. The second was a patient who was whose wife was stuck in another city because of the lockdown, who had been on treatment for more than 20 years, and he stopped taking his medication. He became agitated, violent. He was on the road. The police caught him, but the police refused to help him, though the Mental Health Care Act provides that the police has to take into protection. The father had to lock himself up in the bathroom, gave a call. We were able to connect with the IBHAS and then mobilize a rescue. So that's all telemedicine, and it's all done remotely. And the person is hospitalized and taken care of. And here we have somebody who's already under treatment. One of the challenges, so what can be done is a triage, like has been mentioned, that you can see, you can decide what needs to be done as a further course of action. So one of the challenges which is there is, of course, the medicine list. You can't prescribe everything. On the first consultation, on any platform, you can prescribe list O, which is like vitamins and tonics and so on, or paracetamol. On a first consultation, on a video consultation, you can provide from list A, which is appended to the telemedicine policy. On a repeat visit, you can prescribe from list B. But Schedule X and drugs like benzodiazepines, which are covered under NDPS, are out. They can't be prescribed. So it is great. Then we lobbied for this after the policy came in on the 25th of March through our Indian Psychiatric Society. We lobbied, and on the 11th of April, we got a special order keeping in mind patients with seizures that phenobarbital, clonazepam, and clobazam would be permitted, although they all fall under Schedule X or NDPS. So having said this, the lists in A and B need to be defined, sir, and that's where the role for all of us comes in. From your specialty, what do you want there? One suggestion, sir, last point, could be that the essential medicines list defined under the National Mental Health Program could be put into list A. So that is something which each one of us should lobby for.
I think that because it's a new law, we need a lot of changes, a lot of amendments will come over a period of time. I'll ask specific questions which have come. 200 questions have come. I'm going to take cardiology questions from the Dr. Sethi. One of them is, can images of prescription can be sent through WhatsApp after going through history and report? Dr. Sethi, these are rapid fire, yes or no?
Yes, we have been doing that as of now. The only problem is that the first consultation usually is the more difficult one in cardiology, so it should be in person. Follow-ups are relatively easy. Similarly, emergency, one can see the ECG and make some idea about what is going on, somebody having a palpitation or chest discomfort. So you can say that, okay, this requires an immediate attention or something like that.
What about free consultation?
Follow-ups are a little easier, particularly if you have seen the patient before and the records are available and there is no major change in the patient's symptom. But
so without measurement of blood pressure, how will you advise a medicine for headache? Rashekar.
Can you say?
Yes, sir. So see, the thing is that I completely agree with you, sir. I think that these kind of questions we don't have answers for as yet. And like Dr. Prasanna was saying, over a period of time, we will develop technologies where we will have fundus examination and blood pressure recording, which will be available from home. And otherwise, to start a medication, if a person has it's for a neurologist, we are happier to have a person with long-standing history. Somebody tells me he's having headache for 20 years every day, and he looks fine to me when I'm doing a video consult. I'm less worried about that patient. So it's easy for me to prescribe a medication for that patient. But as somebody comes with a new onset problem, it's always a little more frightening. So in this situation, I think technology as over a period of time will get better and better. And I think now that there is this compulsion, there is this need, I think over a period of time, voice to text will become it'll become probably the norm. And we will just be saying things and they will get typed out over the phone. And these will be well-validated things so that there are no errors and prescriptions and other things in the future. That's
Dr.
what I think.
Do you think that every house or every colony or every every apartment should have one a portable ECG machine, which is like the size of a matchbox, and a SpO2 monitor and a blood pressure instrument, so that people can, whenever they want to, they all can share in an apartment.
Yes, that is very, very valuable suggestion. I think a portable ECG, many devices are now available that look like a telephone, and you put it on the patient's chest and they can record an ECG. So at least for emergency concerns, that can be very, very useful. Similarly, patients will have to be actually taught about how to take the blood pressure correctly. And for once, somebody in that particular society, housing society, or a group of houses can be taught how to record the blood pressure accurately. That is very, very critical, because what I see is that with the spurt of electronic blood pressure recording machines available now freely, we get such variations in the reading, and the patients make so many errors because they do not know how to put the cuff properly, how to seat themselves, and sort all these things. So these things will have to be taken care of. But otherwise, this SpO2 monitor is also very, very useful, particularly for people with respiratory ailments or those who develop acute difficulty in breathing. But having said that, these are all serious emergencies sometimes, that masquerade as some difficulty in breathing and all that. So one should never take them lightly. And even at the slightest suspicion of trouble coming with the patient, you should always advise that the patient needs to go to a hospital or for in-person consultation the next day if it is possible, or the same day if the time and the day permits.
Can you diagnose suspected MI at 3 o'clock in the night on the telemedicine? The patient is having chest pain.
It is very difficult because myocardial infarctions present with so many different symptoms. However, if the symptoms are very, very typical, you can certainly suspect that, especially if the age of the patient is like that and other risk factors are there. And if there is a portable ECG like we talked about just now, and that can be transmitted to the doctor through WhatsApp or whatever. WhatsApp is something that we use very commonly with our residents on duty also at night in the hospital. Then at least a preliminary opinion can be given. But let me also say that one ECG, when taken very, very early after onset of chest pain, does not necessarily rule out a myocardial infarction or a heart attack, and you often need to repeat the ECG. So once again, after talking to the person, one can make a reasonable guess. But since, one is medico-legally liable for all these things, one should never take a chance if you are suspecting a coronary disease. But
how many days of medicine can be prescribed?
How many? Sorry?
Days of medicine can be prescribed. The Delhi Medical Council says not more than 14 days. The same should be applicable here.
Yes, I think so.
The same should be applicable here, and can be charged for the same. There is written in that you can give a receipt. How long the records to be kept? Same as 3 years as for any conventional records with that. Dr. K.K. Agarwal is wearing a stethoscope while giving a webinar. That's always I'm wearing a stethoscope.
Hallmark.
It's my hallmark. Yes, absolutely. And then if any emergency situation like suicidal tendencies, quickly, Dr. Matkal, how to pick up a suicidal tendency on a telemedicine?
Right. So I think just like you would do in a normal conversation, if a person is talking about death, is talking about committing or attempting suicide, it should be taken seriously. Never take it lightly. Even if the person you feel has been threatening or making a gesture in the past, because it can be a real thing. So it's a myth that people will not talk about it. Somebody who's been depressed and talks about, well, if I am alive next month, who knows, or starts making a will, starts giving away favorite things. So watch out for depression. Especially if people have been intoxicated or substance abusers, watch out for that. Having said that, if somebody you know or is talking suicidal, get in touch with a mental health professional. They're trained to handle it. Have a network around you. Secondly, engage the person in a conversation till you're able to reach out to a mental health professional or a trained counselor. Thirdly, refer across. And yes, talking often helps a person to actually get through the moment, survive that moment till the help can be got and the person can be better. So I think that's the best way to look at it.
I'll take 2 more questions before I sum up, because we have exactly 4 minutes for 1 hour to complete. One is for Rajshekhar. Can we declare death on telemedicine?
No, sir. I don't think that should be allowed. I don't think we will be able to do such an examination to confirm anything of that sort on good telemedicine.
Unless you have rigor mortis, you can see in rigor mortis on.
Even with rigor mortis, I think that it'll be. I think there'll be too many legal hurdles here.
No certificate to be given on telemedicine for as death certificate is concerned. Dr. Prasanna, what about GST? Is GST applicable on fee charged?
No. As of now, GST is not applicable to lawyers and doctors. Whatever professional fees that you are taking, GST is not. Anything other than professional income, even if you get for this stock, that is exempt from GST.
So the last 3 minutes, I'm going to sum up. We had 200 questions which have come. I've been able to answer only 30-40 of them. We will take up all the questions and we will generate their answers and send to them individually. It may take a couple of days for us because we are tied up every day with at least 4 to 5 such seminars. But everybody's answers, I have taken out most of the issues I've taken out in the answers. So just to summarize, the telemedicine now is a reality. All of you should be able to charge and do telemedic consultation. That means you don't have to even, you can be at your flexible in giving. It's not necessary that what your clinic timings are. You will be able to charge the same amount of money which you were charging. Let the patient find a platform, let the patient file a call so that there is an implied consent. Even then, you take a consent and keep it with you. In the first consultation, make sure that you have an established identity. So preferably first consultation should be a video call because you don't know from where the patient is calling on telephone. Note his telephone, note his number, make an identity, establish an identity with him or her. For the next 6 months, you don't need to have a consent the same. It will be called as a follow-up consultations. But after 6 months, it will be like a new consultation. Or if the patient develops a new symptom or a new diagnosis, that will be considered as a new consultation. You can consult with your colleagues. You can consult with your seniors. You can have a platform where like for example, my patient wants to consult Dr. K.K. Sethi through me. All three of us can be in the same platform and discuss. The multiple specialities, say for example, a patient of mine is having a diabetology, a cardiology, he has a neurological problem, and he also has a depression. I can have all 4 of you in the same platform with my patient. I can discuss with each one of you together instead of the patient traveling to 4 different doctors and 4 different. And I, as a GP or as an internist, should be able to create that, and everybody gets paid there and then. So a patient doesn't have to go, a doctor doesn't have to go. I should be able to give a second consultation on a X-ray. Suppose I just want an opinion on X-ray and or echocardiogram. Suppose I said, Dr. Sethi, I'm sending you an angio report and kindly give me an opinion. And while giving an opinion, he can be directly showing me the film and telling me what needs to be done. I think telemedicine is going to stay. There will be loopholes because whenever a new act comes, it always have a loopholes. And loopholes, over a period of time, these loopholes will be taken care of. I congratulate all my viewers who have come and taken their time to listen to it. And I thank all my panelists, Dr. Rajshekharan, Prasanna, Dr. K.K. Sethi, and Dr. Sunil Mittal to be here with us. And I thank all my viewers and listeners. Thank you very much. And I say, Corona Namaste, think of asking your patients to buy smaller machines, whether it is ECG, whether it's SpO2. And I close by saying, today the best investment is SpO2 in COVID era, because there is a terminology called walking death. A patient may be walking and he's going to say, I'm all right, but his SpO2 may be 40 or 50. You know he's going to die. You know a patient of complete heart block who may be walking, a patient of acute LVF with hypotension who may be neurologically stable. These are the situations of walking death. So if you have a ECG machine or a SpO2 monitor at home, you may be able to guide them properly, not to travel 45 minutes to come to me, go back to a nearest hospital, which is 5 minutes away. So everybody, I thank everybody, and Vikhyat to say final words from my side. Corona Namaste.
Thank you.
Thank you.
Vikhyat.